Hello, everybody. Welcome to another installment of QTHealth831, a queer and trans health series of live streams put on by or in collaboration between the Epicenter and Dr. Rose Lovell of Natividad Medical. My name is Jacob Agamau. I am the LGBTQ+ services coordinator at the Epicenter. I accept any pronoun used with positive intent, and I am as excited as always to be taking part in this again. I believe that we are making an impact in our community by providing accurate and informative presentations on this medical information. And if you don't know what the Epicenter is, we are a drop-in resource center for transition-age youth, age 16 to 24, located in Salinas, California. We are currently closed due to COVID-19 restrictions. However, in the coming months, we will be slowly but surely opening up to the public. So look out for that at our website, epicentermonterey.org. And with no further ado, I'm going to introduce Dr. Rose Lovell.
Hi, everybody. Yay, we're back. First of all, amazingly, I have to say hi, Mom, because it's her birthday, so I can't not. Hi, Mom.
Happy birthday,
Mom. So as usual, we're going to kind of jump right into it. We do have some disclaimers to start. First of all, my name is Rose Lovell. I'm a physician currently practicing at Natividad. I'm finishing up the third year of my family medicine residency. If you need to go back and get a refresher of what that means, go way back in our YouTube playlist to the first episode where I go over that. And I'm here to talk with you today about feminizing surgery specifically for folks who are trans. My usual disclaimers that I have to say, because I'm a doctor, so I got to say the fun stuff. I have no financial ties to any specific medical treatment, so I'm not being paid by anybody or any surgeons or any companies who make any medicines. The views that I express are my own. They do not reflect that of my hospital, my Laurel Family Practice, which is my current outpatient practice, or that of my residency. I do try to use the most accurate and the most inclusive terminology as possible, but I just want to acknowledge that sometimes not all terminology matches for all people. For example, most people still prefer the term transgender, but there are some people around who prefer the term transsexual. I may or may not be able to use the term that you prefer, and I do apologize for that. I try to be as inclusive as possible. And that information that I'm providing here is really informational only. It does not constitute medical advice. If you have specific questions about your specific medical circumstance, please call your doctor. And if you need help finding a doctor who is LGBTQ inclusive in Monterey County, Santa Cruz County, or in San Benito County, we can talk. Just let us know in the comments, and I'll get in touch and we'll help get you a doctor. Other things that I'm going to add on today for this presentation, I'm talking about feminizing surgeries. I will be using medical diagrams that include images of breasts and of genitals. I will not be showing photos of pre or post-surgical results. If you really want to see those, number one, if you find specific surgeons, they usually have post-operative results on their websites. And number two, there are plenty of places online that put up by the trans community of trans results. I think there's been a long enough tradition of cisgender people like myself in the medical field walking around showing off pictures that, like, I don't want to contribute to that. So if you need help finding a place with good surgical results, again, feel free to reach out, but I won't show photos today. And also, I am a family physician. I'm not a surgeon. I don't do these surgeries themselves. I'm going to do a broad overview, but really, for detailed information, I would speak with a surgeon who actually does these surgeries because they know their field better than I do. I know a little bit about a lot of things. So feminizing surgeries. Let's talk requirements to kind of start. pretty much the same basic requirements for all of them as it is for hormones. You have to either be 18 in the state of California, emancipated, meaning 16 and emancipated, or have your parent or guardian consent. I can talk a little bit, if you folks want, about the youngest age for some of these surgeries. 16 is in general kind of a lower limit for surgeons, and there aren't that many who will do it at that age. Most want 18 or up. You must be able to understand the risks and benefits of surgery. You must be able to express that understanding and consent to treatment. So that's the basic requirements for everything in medicine. As always, I recommend that you have access to psychotherapy. This can be an intense time, lots of pain, lots of things to process, really helpful to have someone to talk to. Also recommend that if you have other medical conditions like diabetes, high blood pressure, depression, that they're under reasonable amount of control. In particular with surgery, you'll get better surgical results the better your diabetes is under control, for example. And that you really, really need to think about fertility with some of these surgeries, and for obvious reasons. If you have testes and you remove them, you will no longer be able to have biological children unless you store sperm. So more than usual, think about fertility. Also, more than usual, even with hormones, your mileage is going to vary much more than your neighbor. Part of that is the particular surgeon and their particular techniques, but also the way that your body heals. And so even with the exact same techniques, no results are the same because the anatomy that you started out with is always different. One person's breasts are different than the other person's breasts. And just a reminder that if you have California-based insurance, so if you have Medi-Cal, for example, or you have particularly Medi-Cal, it is covered by Medi-Cal. All of these surgeries are. What surgeries are available? Generally speaking, breast augmentation, facial feminization surgery, orchiectomy or orchidectomy, it's sometimes called, and vaginoplasty. So let's go through them one by one. Again, I'll give sort of a high overview. I'm not going to talk super detail, but so breast augmentation. In order to get breast augmentation for trans people specifically, unfortunately, the WPATH standards of care do require one letter from one mental health provider. It could be a psychologist, could be a social worker. They just have to be licensed within the state. A lot of surgery practices will provide sort of a list of the things they need for the letters. And if you have a healthcare provider, by the way, who isn't used to providing letters, they can reach out to any WPATH member or anybody who regularly writes letters, and we'll help them figure it out. So you do need one letter, unfortunately, because cis people get breast augmentations without letters all the time. It is recommended that you have at least 12 months of hormones before breast augmentation. I actually, medically speaking, would recommend at least 3 to 5 years, because 1 year on hormones is not going to be the complete breast development that you'll get. And I generally would recommend that you get as much results out of the estrogen and anti-androgen that you're going to before then getting surgery, because you never really know what your results are going to look like, and your breasts are going to continue to change after surgery if you get it at 12 months. But you can, it's just recommended at least 12 months of hormones, not required. The implants that are used in breast augmentation are either silicone or saline commonly. And then just like this diagram shows, they can be placed, so they're placed in the chest. They can be placed either on top of the chest wall muscle, which is the pectoralis major, for those of you who like to do a lot of weightlifting. It's either on top of it, so between the breast tissue and the muscle, or it's under the muscle, meaning, you know, between the muscle and the actual chest wall, just like the diagrams are showing. There are pros and cons to those techniques. There are also pros and cons to where the incision is. So the incision means where they cut. to get into to put that implant in. It can be below the breasts, which leaves a scar kind of like for top surgery for transmasculine folks. It can be around the nipple. It can be in the armpit. It can even be down in the belly button. Depends on the surgeon. So the specific technique that the surgeon uses, the specific implants, whether they're silicone or saline, and the shape of the implants is going to vary fairly widely. And then also your individual results are going to be different, just in particular with the surgery because of the differences in implants and things. Facial feminization is the next one I'll talk about. From my memory, I didn't have a chance to double check this, but I'm pretty sure WPATH itself has no specific requirements, but I have been seeing some surgeons wanting at least one letter from a mental health provider. Why do we need facial feminization surgery? This is an excellent image that I found off of Bone Clones, which is a great nerdy website where you can go get, bone clones. This is fake bone. But I think we all sort of have a sense that testosterone will cause face changes, right? You can look at a person's face and guess whether they are more masculine or more feminine. And that's not just the distribution of fat in your face. So people who have been exposed to more testosterone growing up and through puberty, so cis men classically would be the example, but people with more testosterone have more of a brow ridge. So the bone itself, in this image, it's females on the top and males on the bottom. And they attempt to have different races for good or ill. There's more of a brow ridge, so there's more bone built up there. The angle of the jaw is also more pronounced. There's a lot more bone tissue there. And so that gives you more of a masculine appearance. This section of the jaw right in front is also wider in someone who's had exposure to more testosterone. And in general, the skull itself is just more hefty. There's more weight to it. But from my having done medical school, but not specialize in things like plastic surgery and facial feminization, those are the three aspects I often point to. There can be some subtle nose differences too. Facial feminization surgery is actually kind of a misnomer because it's actually a whole bunch of different surgeries that are folded into one. There are some other things that they can do too. So for those who have had, quote, male pattern baldness, unquote, they can actually take the scalp and advance it so they can lower your hairline. They can do that. They can shave down the brow ridge to kind of reduce the appearance of the forehead. They can do brow lifts, nose jobs, enhance the cheeks, do some lip adjustments. More masculine people with more exposure to testosterone have more sort of a longer distance between the nose and the upper lip. So they can adjust that distance a little bit. They can adjust the width of the jaw. They can shave down the angle of the jaw that's so prominent with more testosterone. They can also shave down the Adam's apple, and on and on. It really depends on the surgeon. I'm pointing out a specific book here on the image. I have a copy of it here, actually, because I'm a nerd. Dr. Osterhout, I have to give him shout outs and I have to give him praise because he literally wrote the book on facial feminization. If you want to know all the fancy details, then I would go ahead and try to pick up a copy of this or try to get it out of a library. It is an older book. He wrote this in, when did he write this? In 2009. And so some of the language is a little bit older. You'll note it says transgendered woman. That was more accepted terminology at the time. But the medical information itself doesn't change. So it's got photos. It's got all kinds of fun stuff. So I would go ahead and check it out if you can. He himself is now retired, but he did practice on. So with a little Googling, you can find someone trained by the person who literally wrote the book. Then there's orchiectomy. Orchiectomy is surgical removal of the testes. It requires 2 letters total from mental health providers, 1 each from 2 different providers, and requires 12 months on hormones unless there's a medical reason not to be on hormones. as I mentioned, it's surgical removal of one or both testes. Cis men, will sometimes have orchiectomy because of testicular cancer. So, I mean, this is a surgery that's been around for a long time. So you can one or both. For transition, it's usually both testes. The incision can be in the scrotum or can be in the thigh, or probably other places. Traditionally, for cancer reasons, it's in the thigh, but for transition, I believe you can get it done in the scrotum too. Just so that you know, some people get orchiectomy and then later desire a vaginoplasty. You can totally do a vaginoplasty after orchiectomy. Speaking of vaginoplasty, this is the most complicated surgery, so it's going to take the longest to talk through. Vaginoplasty is obviously the creation of a vagina. So because it's what ye old cis people would call the surgery in quotes, it does have a lot of requirements because it is much more physically intense than any of these other surgeries. It requires going into the abdominal cavity. It has a much longer recovery time. So there's a much bigger history of cis people saying, but are you sure you really want this done? And so there's more requirements. 2 letters total from mental health providers. Again, 1 each from 2 different providers. You need 1 letter from the person who's giving you hormones, hopefully your primary care doctor, but it may not be. You need to have 12 months of hormones, unless there's a medical reason not to, and 12 months of what used to be called the real life experience. So the way that WPATH phrases this is living in a gender role congruent with one's gender identity. Meaning, if you identify as a woman, you have done social transition for at least 12 months. You are using your preferred name, you are using your preferred pronouns, you are dressing the way like a woman, yada, yada, yada. Unless there is a reason that you can't have done that. In the military, whatever. Will be shot in the street. Good reason not to do it. So those are the requirements. There are a whole bunch of different ways of doing this surgery, but I'll kind of walk through the most common version today, and then I'll talk through some of the other options that exist. Today, the most common version is the penile inversion technique. I'll show diagrams in a moment so you get a sense of what I'm talking about, but basically, you use tissue from the scrotum and you use that to make a set of labia or outer lips, and you take the penile skin and you basically flip it inside out, and it's used to line the vagina. You are going to need some kind of permanent hair removal on the scrotum. Usually electrolysis. Most surgeons are going to require that. Honestly, because they often use some of the tissue of the scrotum to help make the vagina, and nobody wants hair growing out of their vagina. So it's helpful to remove the hair before you use that skin. The surgeons do their best, and their best these days is awesome, to really work to preserve sensation. They preserve the nerves in the penis so that you still have a sensitive, sensitive genitals, and most patients are able to have an orgasm after surgery. Most patients have a very satisfying sex life after surgery. The testes themselves are just flat out removed. I don't know of any cases where they tried to keep them in another fashion, but they're just removed and tossed away. The prostate gland is generally left intact. The prostate gland is deep enough inside that it's really invasive to go in and try to pull it out. Plus, we think that trans women and trans feminine people on hormone therapy are at lower risk for prostate cancer, so there's no reason to remove it. And some people use it for sex, so why remove it? So it's generally left intact. And then a lot of people worry about the depth that they can get with their vagina. Just to put it to rest, you can get just about any depth. Whether you can get depth with only using penile tissue is a different conversation. But if you want a very deep vagina, you can get that very deep vagina. You just may need to get a little tiny bit creative, but it's possible. So I wouldn't worry about it, in other words. This is a great series of diagrams from Johns Hopkins. I want to give them credit for it because I have been looking for diagrams forever to try to explain this and finally found some. So basically, you can see we have a set of different colors here. The teal is clearly the scrotum, and then we've got our penile skin in pink. The urethra is sort of in purplish here. And then we'll go into some of the interior structures. This is using some pretty technical language because it's kind of meant more for doctors, but basically, they take the actual skin off of the penis and of the scrotum, kind of off the other tissues, because they're going to use that skin. They expose the nerves and blood vessels that lead to the glands to the head of the penis, and they do their best to preserve those because that glands, the head of the penis, is going to become the new clitoris. And people like to have orgasms, so they like to try to save them. So at first, all they do is kind of expose things and separate them out. And if you notice, the skin of the penis is kind of a tube. So we'll get to how you use that. In this particular procedure, they make a longer tube by attaching some scrotal skin to the end of the penile skin. So the teal, again, was the scrotum. The pink is the skin of the penis. They take out most of the urethra, the tube through which you pee. And in this case, they sort of open it up so it can be that part of the vagina right on the inside of the labia minora, or the inner lips. They remove the corpus cavernosum. That's the part that gets really swollen with erection. And so vaginas don't really do that in quite the same way. And so it's not really useful. And then they kind of shave down the glands or head of the penis to make a smaller clitoris. And then they put it all together. So you can see, I love this side diagram here on my right hand side that really shows you how the vagina lies inside the body. And so you have the teal here showing where the new labia majora or outer lips get to be. And basically you end up with a new vagina. Again, different people's techniques are going to be a little bit different. This is one surgeon's example of their specific technique, basically, but everybody's a little bit different. To that end, what other versions exist? There's always the fact that any particular surgeon is going to use different tissue. Some surgeons will use the tissue that used to be the urethra, some won't. So there are fine details like that, a little bit like there are with breast augmentation. But then there's the big differences. So there's colon vaginoplasty, which was the original or a much older form of vaginoplasty. Instead of using penile skin and inverting it, they take actual tissue from the large intestine or the colon and graft it in to make the neovagina. It's an older technique, tends to have a lot more lubrication, which is great, but also can produce too much lubrication sometimes. And also there are some specific health conditions where you really can't do that. So an irritable bowel disease is an example of that, because your body would just attack that part of colon, just like it does attack all forms of colon inside your body. And so it gets complicated. But that's one option. Another a much newer option is what we call peritoneal pull through, which requires a little explanation. There is on sort of, if you think about your belly, your abdomen, there is a lining to it called the peritoneum, and the peritoneal pull through technique basically takes some of that peritoneum and pulls it through to the vagina to make a new vagina. We've been using peritoneal tissue for much longer for women who are born with intersex conditions who don't have a vagina to start with, but they're cisgender. So there's a little bit of history to that, and in their case, they have no vagina, like they have no scrotum or penis, the structure's never formed. So it's a little bit of a different situation, but that it's starting to come through from that literature and that world into the transgender surgery world. And so I'm seeing a few surgeons now offering this. There's also just an absolute explosion of more creative surgeries as opposed to just the, well, you have a penis or you have a vagina. So there's minimal or zero depth vaginoplasties as well. In the old days, there was a big emphasis on, well, you have to have this deep vagina because you're going to put penises into it. And so they assumed that everybody was heterosexual and would want that kind of sex, but not everybody wants a deep vagina. So there are some surgeons who are doing minimal or zero depth. There's also the two-stage technique. This is an older technique. Again, not as old as the colonic, but basically in one surgery, you create the vagina and a little bit of the labia. And in a second surgery, you go in and you deliberately plan a second surgery where then you go in and you really refine the appearance of the clitoris and the labia. It's a little bit less in favor these days, actually a lot. I know very few surgeons who are still doing it, mostly because you have to have 2 surgeries instead of 1. And then there's penile preserving, which I have found a total of 1 surgeon so far who does it, but it may be an option. And if that's important to you, I would seek that out and find the surgeon who does it. The vagina needs a little tender loving care. In particular for a post-operative vagina. So sometimes we call it the neo-vagina because it's new. So the vagina does need, if you have depth to it, it is going to need to be dilated lifelong to maintain that depth. Having penetrative vaginal sex may help, but really I would plan to do some form of dilation lifelong. Usually by the time it's well healed, only once or twice a week. I have on the screen here also an image of a set of one particular set of dilators. They are commonly hard plastic. They used to be glass in the old days. Some of them have sort of a curve and a little bit of a taper. They get narrow at one end. Some of them don't. I would use the set that your surgeon recommends. The vagina will also lubricate, but the amount that it lubricates really depends on the surgical technique, but all of them will. And then in terms of postoperative care, you really lifelong, there's not a good reason for regular speculum or pap exams. The pap exam for people with a cervix is intended to screen for cervical cancer. That is the only part of that examination at this point in time that I have solid data to justify, unless there is a problem. OBGYNs in particular will still be doing what's called the bimanual exam with that and checking the uterus and the ovaries and all that stuff. But really a pap exam where you put a speculum, that metal or plastic device, into a vagina to look at the cervix and look at the inside of the vagina. There's really not a lot of reason to do that on a regular basis for a postoperative or neo-vagina. There's no risk for cervical cancer because there is no cervix. I've known some folks who prefer to get one regularly because it helps with their dysphoria. And I have heard of some physicians making an argument to do it regularly to look for skin cancer. It's not part of my typical practice, but generally speaking, unless there's a problem, you don't need that exam. It's okay if you don't want one, but you don't need it. So what are the risks of surgery? I'm going to speak pretty broadly to start with. Anytime that anyone cuts skin, even a physician, even a surgeon in the middle of the OR with all of our cleanliness, there's always a risk anytime any one of us cuts skin. And number one is the obvious, it's infection. The skin is there to help protect us. So if we cut through the skin, there's a risk of infection. And I'm going to try not to beat on the worst case scenario, but part of me talking about this is also trying to help you understand, like, there are risks to surgery. Surgery is not benign. So infection, in the worst case, that infection can go to the bloodstream and make you very seriously ill. There's always the risk of bleeding. The risk goes up the more that we cut and the deeper we go. So it's much higher in vaginoplasty than it would be in a simple orchiectomy, for example. Any loss in sensation or a change in sensation. So anytime we cut, there's the chance that we'll hit a nerve. We don't ever mean to, but that is always a risk anytime that we're cutting through skin. There's always the chance that there's going to be a problem with the wound healing. This includes what's called dehiscence. So when we stitch two things together, when we suture things back together, there's a chance that that could then open up again and that it doesn't heal nicely. That's dehiscence, just a fancy way of saying it. Or that some of the tissue that we've moved around, for example, in vaginoplasty, there's always the chance that some of that tissue, like deep inside the vagina or the clitoris itself, even can die. It's called necrosis. We kind of watch out for that. That's a risk. And then there's the risk of what's called a seroma or hematoma. A seroma is when fluid just accumulates. It's what's called serous fluid, that yellow stuff that's in your blood, if you've seen the fancy little diagrams. Or a hematoma, which is a fancy way of saying a really big bruise. And then obviously, anytime we cut skin, there's the chance of a scar, which could turn into a big gnarly scar that we call a fibroid. Anytime that we do general anesthesia, meaning we put you to sleep, there are other risks. So there's the risk when we put you to sleep like that, we have to put a breathing tube down your throat and we have to have a machine helping you breathe. We have sort of, in the course of surgery, we really have to take over those functions for a little bit because of the effects of the medicines that we give. Sometimes we need to paralyze you while you're asleep and you can't breathe on your own if you're paralyzed. So there are risks from the tube. The biggest one is pneumonia, because you can't cough and protect your own lungs. You could have bad reactions to the medicines we give to put you out. You can have things like blood clots. Surgery itself, general anesthesia in and of itself, is really stressful on the body. And so if you're at risk, particularly if you're at risk for it, heart attack and stroke can happen. And then honestly, always with surgery, there's always a risk of death. There's always a risk of death at any moment, at any time, but there's always a chance you might not wake up. It's rare, but it happens. There are some specific risks of specific surgeries that I want to touch on. For breast augmentation, there's a risk that the implant that they put in can leak or rupture. Particularly if there's trauma, you get into a car accident, something hits your breast, there's a chance it could break. Specific implants have specific risks as well. Silicone is slightly different from saline, so I would ask your surgeon on that. For vaginoplasty, there's the risk of what's called a fistula, meaning that there is a connection between two parts of the body that shouldn't be there. The two common ones, and I have a diagram here on a body with a uterus, but the point is the same. So a connection that forms as your body heals between the vagina and the rectum. So meaning that, between your vagina and where your poop is, you could have poop going through your vagina, or between your urethra or bladder and the vagina. Fistulas can happen for people who have not had surgery in that area too, but it is more common if you have surgery around your genitals. And as always with surgery, there's always the risk that you're going to need more surgeries, either to manage a complication or a bad outcome from a surgery, or just to do further aesthetic adjustments, like how that second stage for vaginoplasty was planned for some forms of vaginoplasty. Sometimes, like, your clitoris is too big and it's super sensitive and it's driving you nuts and you need it shaved down. These are general risks. I would talk with your surgeon. It's part of your surgeon's job to discuss all of the risks and benefits of their surgery with you in detail. If you feel like you don't understand the risks and benefits of the surgery that they're talking about, you can stop them. It's part of their job to walk you through that process. And the person who does the procedure is the only one who really can or should do that. For example, I can't walk you through all the risks and benefits because I don't know them all, because I don't do the procedure. If I'm putting in an IUD, that is something that so that's my job, but it's a surgeon's job to walk through the risks and benefits of surgery. So I would pin them down. How do you prepare for surgery? How do you get the best outcome that you possibly can? This list is going to look familiar if you've watched the other talks. In general, to reduce your risk with surgery, be as healthy as you can possibly be. It's got a good list of things, and you've probably heard these all from doctors before, but we'll go through them real quick. So one is don't smoke tobacco specifically. If you do smoke tobacco, quit at least 2 months before your surgery. If you're still smoking the day before surgery, keep smoking through the surgery. But in general, don't smoke tobacco. You will have much better healing and much better aesthetic results if you quit at least 2 months before your surgery. Exercise regularly, at least 30 minutes 3 times a week, which is the CDC's recommended minimum. Eat a balanced diet, variety of food, mostly plants, little to no added sugar, watch the McDonald's, definitely boycott Chick-fil-A, all the good stuff. Do your best to maintain a healthy weight. Historically, there have been some surgeons who refused to do this kind of surgery on anyone who was overweight. That's less of an issue these days, but the healthier weight you are, the better aesthetic results you're going to have, the better healing you're going to have. Make sure you get all your recommended blood testing. And then just remember, try not to get a sexually transmitted infection, get tested regularly, all that good stuff. So that's the core of my presentation today. I want to kind of pause, let some of that sink in, because unfortunately I had to use some really, really medically terms. And I want to open it up to questions now.
Hi, I'm back.
Hey, welcome back.
All right, so we have a couple questions. First, what's the reason why it's recommended to stop smoking 2 months before surgery?
It's a funny thing. So it turns out that when you quit smoking, for a while, you actually end up basically hacking out all of the stuff that that the cigarettes put into your lungs. And all of that mucus, all of that phlegm, all that icky stuff that you spend coughing up can really get in the way when someone puts a tube down your throat, and it raises the risk that you'll have pneumonia. You need about 2 months or 8 weeks to clear all that stuff out, and for the bronchi, the tubes that go down into your lungs, tube that then becomes more tubes, for them to really clear out and get healthy enough to tolerate a tube going down. So I wouldn't quit the day before. I would quit at least 8 weeks in advance.
Okay, well that makes sense. Let's see. What is the typical post-surgery downtime? Like, how long would a person be in the hospital? And if they transfer back home, how long would they be recommended to stay off their feet and all of that?
Yeah, depends a little bit on the surgery. Orchiectomy is probably the simplest and least invasive, and that is a same-day surgery. So you go in, you have your surgery, you go home the same day. You will be sore and definitely off for a couple of days to a week or two, and then you'll be back up on your feet. It's more invasive than a vasectomy for sure. A vasectomy, you don't even need to be knocked out. Most people knock people out for orchiectomies. Your surgeon will tell you all of this in detail, by the way. They want good surgical results, so they will give you big paperwork, lots of paperwork with lots of details. On the other side of the spectrum, it's vaginoplasty, where I've heard surgeons wanting patients to stay in the area, stay in a hotel room in the area for at least a week or two, meaning you're effectively hospitalized for that time. Probably you could actually go to the hotel room in a couple of days, but it is what we call major surgery. And what doctors mean when we say major surgery is we just opened up your abdominal cavity. And anytime we do that to someone, your body feels and acts like it just got hit by a truck. And so it'll be months before you're really back up on your feet.
Right.
Definitely be careful with cats around because they may try to jump on sensitive bits.
Yikes.
Not that that's happened to anyone I've ever met.
Yeah, I can only imagine like the trauma that your body actually goes through, that it needs time to calm down, I guess you would say.
But on the other hand, I mean, I talk a lot about risks simply because that's part of my job, but the benefit here is huge. Like, it gets rid of that dysphoria permanently. Like, if having a penis is part of your dysphoria, this just treats it. This fixes it. You can have vaginal sex. You can go into a women's restroom and not have somebody ever freak out because now you completely pass. If I can be excused for using that old terminology, but in my opinion, it helps reduce the risk that you'll be assaulted. So I've long made the argument with other doctors that, like, hey, but this is a safety issue. This needs to be covered by insurance because it's a safety issue. There are tons of benefits. It's just also something where you have to understand that you may not necessarily get 100% the results that you dreamed of. So it's important to be realistic going in.
Mm-hmm. And sort of on that same note, like, would anyone looking at the surgically created vagina be able to tell it was surgically created?
Generally speaking, no. It will totally depend on surgeon, and it will depend on how your body healed. But definitely in a locker room situation, definitely nobody will know. I have heard from patients before that they've had OBGYNs do like vaginal exams and could not tell that they had had surgery, could not tell that they'd had a vaginoplasty. So again, your results will vary a bit. I think we tend to have this perception that all vaginas look the same. That, all vaginas have, these nice, tidy little labia minora in the middle that tuck away and hide away and you never see them, and they're all symmetrical and they're all shaved or they were blonde. And that's just simply not the case. And so one of the things that I've talked with people about before is, like, there's a huge variety of anatomy when it comes to cisgender women. And so really, trans vaginas that have been created through surgery, through a piano inversion, fit right into the spectrum of what you normally see in a human population. The problem is that we've all forgotten what that looks like. Right. Because we never look at vaginas. So there are some really great projects online where you can go look at some vaginas on your own, assuming you're over 18. And I recommend doing that to also help ground yourself in a sense of, oh yeah, this is what normal looks like. Mm-hmm. This is what it actually looks like, not just what it looks like in porn.
Absolutely. And every vagina is a blessing. Let's see. In terms of vaginoplasty, does it matter if the patient is originating as circumcised or uncircumcised?
Not even slightly, from what I've heard. Will they use the tissue? Depends on the surgeon, but does it really matter in the long term? Typically not. I've never heard, and although I am not a surgeon, I speak from the experience of having gone to a lot of conferences and hearing surgeons speak, both to patients and to other doctors. And granted, the bulk of that was a couple of years ago, but I've never heard a surgeon say it mattered to them in terms of being able to have results that made the patient happy.
Okay, good to know. Another thing is there any such thing as having like a vocal cord surgery or vocal surgery at all?
Yes, there is, and I'll caveat what I'm saying is in that I have not looked into it for a number of years, so things have probably changed. There is a surgery where they can go in, if you remember that testosterone makes the vocal cords really thick, and that's what makes your voice drop. There's a lot that you can do with your own voice to help raise that, but that damage, that thickening, can never, like, hormones can't change it. and vocal training also can't change that. So the only way to actually change the vocal cords themselves is to go in surgically and shave them down. The early attempts at that were a little bit inconsistent from what I remember from hearing. That was the gestalt or the general feeling within the medical community that I was around. The surgery absolutely exists. I would check in with your local support group and see what the current thoughts are, and I would also talk to a surgeon yourself. They're classically, we used to talk about a risk that you would end up sounding like Mickey Mouse, that your voice would end up super high by accident because maybe they shaved it down too much. I don't know what the data are like on that currently, and I really ought to go look it up. But there is voice surgery that does exist. I don't think WPATH has any specific preoperative requirements for that, but I would expect that the surgeon would probably want a mental health letter at bare minimum. One of the other reasons that it's good to know a social worker or a psychologist.
Right. And we have a lot that are just very willing to write that letter with the proper diagnosis and all of that. So yeah, the options are out there. I don't have any more questions regarding this topic. I did want to sort of just like touch base about how things are going culturally right now with the world seemingly opening up a little bit more. The governor saying that we want to be fully open by mid-June. I think that was what he said. I know that I have a lot of like apprehension about that. I think it's a bad idea to tell the public that we are aiming for this date so soon. What are your thoughts on that?
I'm inclined to agree, mostly because I want to see more people vaccinated before we really, really, really open up. We're already seeing COVID cases go up elsewhere in the country, not here in California. But if it spreads in one place, unless we have some level of herd immunity, which is a phrase that gets thrown around a lot, but basically, unless the majority of the population is vaccinated so that it can't spread, because remember, no vaccine is 100%. Yep. Our current vaccines are really effective at preventing what we call mild illness. So getting the sniffles from COVID. Frankly, as a doctor, I care that you got the sniffles from COVID, but I care a lot more, and most of my patients care a lot more if they got hospitalized or died from COVID. And so that's the big difference actually that you see in the vaccine data, the Pfizer, Moderna versus the Johnson & Johnson. All of them are effective at preventing hospitalization and death. The difference is which ones are better at preventing mild illness. And I'm like, well, it's a sniffle. Come on. So I am also fairly concerned. I do encourage everybody to get the vaccine, whichever vaccine you can get your hands on. Does not matter which one. Of course, and I should say, yes, there has been some news, brand new news about the Johnson & Johnson vaccine. What I have heard so far, I have not had a chance to read all the data myself, but what I have heard so far is that we are holding it. And the reason why it's being held is so that we have the time to dig into the data and figure out what happened. What I heard is it's maybe six people, and it's being done out of an abundance of caution. We don't necessarily think that there's a problem, but we want to pause, take our breath, and look closer at the data to figure out if there's a problem or not. This doesn't mean that anybody failed at their job. It actually means the system is working perfectly because we've built all of these safety features into the way that we do vaccines, into the way that we do medicine trials. We learned in medicine, we learned a lot from our early failures. We learned a lot from the thalidomide debacle, which you may or may not have heard of early on. From vaccines where there were more issues, like the oral polio vaccine, where people could get polio from the vaccine, actually. We build our vaccines differently now. So the fact that we're pausing that vaccine is, to me, a sign that we're doing that our systems work. So I think the most important thing to do is get vaccinated. The second most important thing to do is to continue to do all your social distancing. Wear a mask in public, Don't hang out with a bunch of unvaccinated people. Wash your hands, although that's much less important than wearing a mask. I do recommend following the double masking if you're able to, recognizing that that's not always possible. Some medical places actually even say don't do that when you're working in our hospital, because the N95s haven't been tested for that, and it's this whole thing. But do everything that you can do. Act like the pandemic is still going, because it is. If you look at the data, I like the graph that's on the Washington Post website, but I'm also a fan of the Washington Post, so I'm biased. But if you look, every time that we've come down from a peak, we don't go back to where we were before. We stay at a higher level. The pandemic is still going, and it won't stop until we all get vaccinated. And we can't all get vaccinated immediately because our health system isn't designed for it. We are still being very slow at rolling it out. I would do everything you can to encourage everyone to get vaccinated. Long story short. But we are still in a pandemic.
Yeah, we are not out of the woods yet, and I think that's something that needs to be said like a lot right now. Just because we have people saying, "Oh, we're going back to normal in 3 months." Like, that's not the case. Like, I wish it was. I wish we could all just go ring around the rosy in the park, but unfortunately, that's not the case at the moment. Yeah, like it's so disheartening, because I know I get like how much we want to just see our people again and gather in bigger groups and have birthday parties and have a 4th of July barbecue and all of that, but we need to stay vigilant and keep ourselves safe and keep each other safe, like, by doing that.
We really do. It's I when I talk with people about it, I've had some patients say to me, doctor, I'm really scared of the vaccine. And I think we talk a lot about the risk of vaccination. And the fact is that this isn't about whether you feel a little bit sore the next day or you feel tired and want to go take a nap the next day. This is about preventing death, and it's not just preventing death of your death. I don't care if you're 25 and a bodybuilder. I've seen the equivalent 25-year-old bodybuilder types die or get very close to dying before from COVID. It is so much worse than flu, and flu was already doing that. This is about, yes, it's protecting those, but it's protecting our elders, the people who remember the old times, the people who have knowledge, who love us and who we love. It's about protecting our small children who, yes, they do better, but they are still at risk of dying. Like, anyone who gets COVID could die. And so we're really preventing death and destruction and cultural destruction of our local communities. Like, I stumble because it is so very important, the work to prevent COVID spread and the work to combat this pandemic is that important. And it's, in a way, it's been really good that we've been able to keep people out of the hospital, like not having visitors in our hospitals. But I think also we've missed, it's hard for those who haven't been in healthcare to understand how devastating this has been. Watching whole families die, seeing a husband and a wife both getting COVID and one walking out of the hospital, well, not walking, one being wheeled to a rehab center and the other one not making it. And that's something that I think people miss is, yeah, oh my God, it's scary that 6 people got a blood clot. You are much more likely to get a blood clot and die from COVID if you get it. And it's coming back. So, and we're getting variants, and it's scary times still. So I know we're all tired. I want to go hug my mom for her birthday as much as anybody else. But it's just not safe.
Yeah.
Pandemic's not over yet. So we got to stay home. We got to play our Pokemon Go by ourselves with our masks on. Go play some Pokemon Go. It's good for you. Don't do the GPS trick. Go walk. But it's not over until it's over, and it's not over yet. So thanks for bringing that up. It's super important to honestly the work I do every day.
Yeah, it's important to me just to bring it up at every chance I can, on every platform that I can, whenever I can, just because I want to see the people that I love. I want all of us to be together on the other side of this. I feel very fortunate to have not lost anybody to COVID-19, but I know that we're not out of the danger zone yet. And so I want to make sure that everybody knows that I'm concerned about them. I'm scared for them. I'm scared for their families. And I just want us all to sort of make it through.
Yeah. And I think the aspect that that at least I see the white community not talking enough about is how much this so much more affects our non-white communities.
Mm-hmm.
And so it's perpetuation of racism, basically, only in a viral form. There's only one way to combat that.
Yeah.
So I just feel like I have to mention that.
Yeah.
At every turn.
Health inequities are ever present, inside or outside of this. So I want to thank you so much for just being part of this and for being our guide through this, basically, because the information that you're able to provide for us as a medical professional is just invaluable to our community. And so thank you, Rose, for that. We can go ahead and end this on a on a downer
on a somber note. Get your vaccine.
Yeah.
Encourage other people to get the vaccine. In Monterey County, you can go to mcvaccinate.com to figure out where you can get your vaccine. Santa Cruz County, I've had more trouble. I don't know if you've had better success. I just go to Santa Cruz County vaccine and I just refresh the page a million times.
No, we're getting our vaccines in Monterey too. So that's helpful for us.
Yeah, for those who live in Monterey County, also Natividad is starting to do some mass vaccination clinics. So please come down, bring your friends. Everyone at Natividad speaks Spanish except me. It's fine.
And also, didn't things like officially open up for, I think, everybody, or is it people over the age of 16 as of today? I forget what the.
I think it's everybody over the age of 16 currently. Okay. I think it just opened all the way up. Which you might have to refresh that page a lot of times. Also, a fair heads up that Rite Aid is, although they are providing vaccines, they do ask for sex assigned at birth on their online page. I need to send them a note and be mad at them. I can say that if you can tolerate going through that, the process in person does not ask you for that. So I would put your current gender identity because they don't use it for anything medical. There's no medical justification to ask that. Yep. So just FYI for our trans audience.
Great tip. Thank you.
Yeah. Ignore them and then go yell at them.
Yeah. Well, yeah, that's it for us this month. I believe we'll be back next month. Is that true? Or are we going to take a
Yep.
month? Okay.
So let me check my calendar, but I think it was May 3rd. Nope. June 3rd.
Okay. So we're taking a month off.
We are, because I go back in the hospital for 5 weeks. So please don't get hospitalized at Natividad, and you might see me. So May 3rd at 6 p.m. currently, we're scheduled to talk about masculinizing surgery. So we'll talk about metoidioplasty, phalloplasty, top surgery. There'll be more diagrams, all kinds of fun stuff.
Wait, you mean June 3rd?
June 3rd. I meant June 3rd.
Okay. We're both confused. It's fine. But yes, thank you all again. We will be back on June 3rd. And in the meantime, stay safe, wear your mask, wash your hands, drink some water, be nice to your family or whoever you're sheltering in place with. Do your part just to make this situation a little bit better, one step at a time. And yeah, I think that's it.
Absolutely. You said it all. Stay safe, everybody.
Good night.